Okay, this next session is called Bridging the Gaps Through Telemedicine. I'm your moderator. My name's John Kornak. I am the former director of telehealth at the University of Maryland Medical Center, just a few blocks up the street in Baltimore. So this session, the objectives are to highlight existing telemedicine models for providing genetic services, including the barriers to implementation of these models and the benefits to individuals with genetic conditions and susceptibilities. We're going to also discuss different distance strategies, including telemedicine, to increase access to care. First off, a brief definition. HRSA defines telemedicine as the use of electronic information and telecommunication technologies to support long-distance clinical health care, patient and professional health-related education, public health, and health administration. The American Telemedicine Association defines telemedicine as the use of medical information exchanged from one site to another via electronic communications to improve a patient's health status. This also includes a growing variety of applications and services using two-way video, secure email, smartphones, wireless tools, and other forms of telecommunication technologies. With those definitions out of the way, I'd like to introduce Alyssa Terry. She's been a genetic counselor at Ferry Institute. I knew I was going to butcher it. Ferry Institute in Binghamton, New York for 10 years. Alyssa is a 2002 graduate of Cornell University with a Bachelor of Science in Biology and Genetics. Prior to her career as a genetic counselor, she worked at the National Institutes of Health studying breast cancer, protein biology. Alyssa is a graduate from the Johns Hopkins NIH Genetic Counseling Program. She provides various lectures to community organizations, students, physicians, and other health professionals, and has consulted with NYS Congenital Malformation Registry and collaborated with NIMAC on several projects. Alyssa is a member of the National Society of Genetic Counselors and received her board certification from the American Board of Genetic Counseling in 2007. She joined the Community Genetics Program of the Ferry Institute in 2006 and plays a role in both clinical and non-clinical programs. Please welcome Alyssa Terry.
Today I'm going to give updates on two collaborative programs that we did with NIMAC, both related to telegenetics. Luba and I come from the Ferry Institute, which has over 30 years of history as an independent nonprofit community genetics provider in upstate New York. We have a unique background in providing clinical services, education, outreach, and telehealth in both teratology and genetics. And we recently developed a unique tool to improve the integration of genetics into clinical care called Genetic Help Desk. In 2016, we worked with NIMAC on two projects. I shared preliminary progress on the first project at the NIMAC meeting in May, and today I will give an update and summary on our project focused on integrating genetics into clinical care in community hospitals. I will then provide an introduction, preliminary findings, and plans for the telegenetics landscape survey and establishment of the telegenetics community of practice. More information will be shared about this latter project tomorrow during the telegenetics session. So again, just as a frame of reference, our projects have chosen to use the same telegenetics definitions as the NCC telegenetics work group. They're both here, HRSA and ATA. And as was decided by the NCC group, both definitions are broad and would encompass phone counseling as long as it's appropriate to those particular activities. And so far in our projects, we have included it in our activities. So our first project explored integrating genetics into clinical care in community hospitals in the NIMAC region. This involved a needs assessment of select providers and a demonstration of our Genetic Help Desk tool. So Genetic Help Desk is both a collaborative reference service and a telegenetics service. For the provider reference service, healthcare providers have both phone and email access to our genetic counselors for any questions related to genetics in their clinical practice. And in the patient telegenetics service, referrals can be made for phone or live video consultations. The Genetic Help Desk website was also available to the program providers and has clinical guidelines, point of care tools, and other useful links and resources related to genetics. So the project consisted really of three distinct phases. The first was a baseline needs assessment of 56 rural community hospitals in our region. The next phase focused on hospital and provider invitation and engagement, and the last was genetic help desk utilization. So when we looked at phase one, our baseline needs assessment, phone calls were made for a scripted interview to 168 practices from 3 providers from each hospital. After repeated attempts at this, we received only 29 responses, and a lot of the surveys were incomplete. But what we saw was that 8 out of 16 said they offered genetic testing, only 1 out of 24 said they had a genetic counselor in the office, but 6 out of 6 said that when genetic counseling is provided, it's a doctor who does it. Most said they do refer for a genetic counselor when needed, and most also said that their patients do follow through with these referrals. The most interesting finding was that only 7 out of 25 said their practice would benefit from access to a genetics provider. 18 out of 25 people said no to that question. Typically, they indicated they just didn't have enough patient volume or just refer out when needed. So these practices were either unaware of their access issues or they thought we were asking whether they needed a genetics provider in their practice. We're not quite sure which. So next we refined our target group. To supplement the survey data that we got, each hospital was also categorized as whether or not they had a genetics provider within 50 miles, and also whether the hospital or practice website made any mention of genetic services. 16 hospitals were found to already have genetic services or offered such a limited spectrum of clinical care that it didn't really fit the project. So this left us with 40 hospitals. 28 were offered the provider reference service only for 1 primary care provider, 1 OB, and 1 oncology group per hospital. And then 12 hospitals were offered both the provider and the telegenetics services. When we were selecting those 12 telegenetics hospitals, our priorities were to look for hospitals that were definitely geographically underserved. They had no established services within their health system. They had a lack of genetics information on their website, and also locations where Genetic Help Desk was able to comply with licensure laws, which we could do in New Jersey and Pennsylvania, but we're not able to accommodate in Delaware. So with those practices assigned, we moved to hospital and provider invitation and engagement. So this was quite a process. In the very beginning, when we were collecting our baseline phone data, the CEO of each hospital got a letter from us explaining that we were exploring access in their region. For the practices only being offered the reference services, we then mailed a packet to 84 practices with a letter of invitation and some tools. We followed that with a phone call to each practice to attempt an interview. This resulted in just 2 phone meetings with the genetic counselors and a lot of people making requests for fax or email information. We then sent a series of 4 reminders about the project, 1 at a time, over the next several months. When we look to the right for the telegenetics group, the first thing we did there was that the genetic counselors tried to call to engage the CEOs of each hospital, and we were incredibly unsuccessful in getting through to them. We did engage 3 CEOs through an established relationship that we had with a primary care provider in their area. This led to leadership meetings with 2 CEOs and 2 medical directors. They then turned and had emails and conversations between the leadership and the doctors. At that time, we then sent them the packet, followed with a phone call, and sent all those reminder mailings. When we did not reach the CEO, we instead just went straight to mailing the packet and then followed with a phone call and the reminders. So this is just a quick look at the letter of invitation, the bookmark that we sent, and the point of care tools. So each practice, depending on their specialty, received a different sort of indications for a referral sheet from us. And these are some of the things that went out in those subsequent mailings. And I'll just add that in all the approximately 150 phone calls that were made in follow-up to these mailings, programs usually did not respond, did not remember getting these materials, and occasionally asked for more information. But offices who received communication from their hospital leadership were much more receptive to our calls. So lastly, we can look at actual genetic help desk usage. We did see an increase in the traffic on the Genetic Help Desk website. If you compare the 2 months before the project to the 4 months the project was active for providers, we see a 49% increase in unique visitors, 36% increase in number of visits, and a 22% increase in the number of hits. So it does look like the providers may have been visiting the website. We ended up receiving 24 telegenetics consult referrals toward our original goal of about 30. These all came from 3 hospitals which were geographically closest to us, so they were all about 2 hours away, sort of within that window. 20 referrals came from 5 different primary care providers, 3 from oncologists and 1 from an OBGYN. The indications predominantly for hereditary cancer, but we also saw things like hypermobility, infertility, hereditary cardiovascular disease, and pediatric overgrowth. And almost all the patients that were sent to us met established guidelines for referral. There were 10 patients who either declined, were not able to be contacted, or died during the course of the project. Some of these cases are still in process, and unfortunately, the new video technology system that we purchased to be used in this project was never actually successful, so these were all phone consults. Over the whole course of the project, only 3 calls or emails came in for the provider reference service. Some of these were not clearly project participants, and 1 primary care provider did have their patient call to ask us a question instead of calling themselves. So if we look at the 11 cases that are done so far, outcomes include that there were 2 cases where we reinterpreted previous test results in the family and recommended updated testing, 5 cases where the patient elected to pursue testing themselves, 3 cases where we recommended a family member be tested. In 6 cases, we referred the family to some other provider. It might be another genetic counselor, geneticist, cardiologist, fertility specialist. And in 3 cases, we referred for evaluation of an unrelated issue that was not the indication for referral. This included 2 situations of cardiac evaluation due to significant family history of sudden cardiac death among patients who were referred for hereditary cancer syndromes. I think this is an important aspect of genetics consults to keep in mind. It's also been shown to happen in about 10 to 15% of prenatal genetic counseling consults. So overall, we've gotten very positive feedback from both providers and patients. They are happy to have another option for services, pleased with the convenience and the short wait time, and we've received a lot of remarks on the thoroughness of the service. So when we look at the impact of this project, it was clearly different from what we were expecting, with less phone survey data and few provider reference calls. But what we did accomplish includes that 14 patients will receive genetic counseling services that they almost certainly would not have otherwise. 40 community hospitals and over 100 practices received educational materials and indications for referral documents, which even if they don't use to come to Genetic Help Desk, we're hopeful that they can still use them in patient evaluation and referral. And some providers were utilizing the website, which also has a lot of useful information on there. 3 community hospitals near us that had previously almost never used our services did engage with us. And as a result of this, conversations are ongoing with 2 hospitals about how to establish a collaboration for continuing this service. And the 3rd hospital is currently hiring their own full-time genetic counselor. Also through this project, trends were identified and lessons learned that will shape future outreach efforts to improve access to genetic services. So let's think about those for a minute. Some of the trends we found in this project was that there was really a general lack of awareness and motivation for change. When we tried to reach the CEOs and the office managers and the providers, they were really not aware that they had an access issue and were not feeling a need for genetic services. There was definitely more interest in the telegenetics consults than the provider reference service. This may be because practices are used to referring out, and it was really harder for them to conceptualize how to utilize a reference service. Most of these practices are not ordering their own testing, so they wouldn't be calling us with questions about test selection or result interpretation. And practices often felt that travel was their biggest access issue, and that was probably easier to understand how to address that with telemedicine. We also found that the primary care doctors were using the service most. Partly because, at least in some cases, specialists were doing their own testing, some of the oncologists in particular. And we also found that some practices were just used to referring to very distant locations, like OBs that always refer to their regional perinatal center. So some people just have systems in place that they're comfortable with. Really, the biggest lesson we learned is that relationship building and engagement is really challenging. We really had a short timeline here. Often just as we were engaging a group, the project maybe only had 8 to 10 weeks left. We really feel that aggressive targeting is needed, and that was something that was outlined in the NCC brief on regional models. We sort of wonder now if starting with a smaller hospital group and building up would have been a better way to connect with them. We certainly found that having a connection within the system opens doors. There's a huge advantage of hospital leadership support and invitations in terms of the doctors responding. And we know now that we probably need to look at different mechanisms to engage providers in these outreach projects. So someone mentioned earlier the NIMAC Genetics Education Network. Perhaps using provider email lists or in-person visits would have been more engaging for these community providers. So when we think about where to go next, as I said, we're trying to continue services to the hospitals that did use us. We're also thinking about providing technology to the doctor's office for patient consults, like iPads or tablets, and then the referring doctor could also be billing on their end. As we plan for the future, we have to be aware of various changing landscapes. So more telegenetics providers are becoming available across the country, as I'll describe in the second half of my time today. More hospitals are becoming part of health systems, which makes it harder sometimes to evaluate true access, since a provider in the system, it could still be 2 to 4 hours away. And genetic counseling licensure laws are evolving, and that's important to any telegenetics service. Lastly, in the future, we would love to do some sort of genetic help desk quality improvement type of evaluation using those NCC telegenetics evaluation measures, which are still being put together by the telegenetics evaluation work group. So with that, I want to thank all the people at NIMAC, as well as my colleagues and staff at FARA and our consultants who made a lot of these phone calls for us. And I'm going to transition now to the other project that we worked on this year, which was really focused on assessing and supporting telegenetics in the NIMAC region. So this really got started because as an access to care issue, NIMAC wanted to better understand what was going on in terms of telegenetics and what the needs were for the providers in our region. A general inquiry was made to genetics providers about who was doing telegenetics and who was interested in it. We then followed up with a survey to learn more about existing, planned, or previous programs, and a small survey to learn about the educational needs for those who were interested. This information formed the foundation of the telegenetics community of practice, which I will describe. So as I said, our first question was, who is doing telegenetics? We sent emails, made phone calls, posted on listservs, reached out to state genetic counseling groups, and found that among 175 identified genetics facilities in our region, 27% of responding facilities do some telegenetics. So this was 39 different facilities in the NIMAC region providing some sort of telegenetic services. We had an 80% response rate for the facilities, and it's important to note that several facilities have more than one telegenetics program, so some of the big hospitals might have prenatal and pediatrics and adult, and that's not reflected here in that number of 39. But not included here are national labs, national telegenetics businesses, or telegenetics in other regions that might reach our patients, although we do account for them in the next phase. So really we were all a bit surprised by what we found and realized all that was already out there. And NIMAC was motivated to learn more. Now that we knew who was doing it, we wanted to know what, where, when, why, and how they were doing it. The NIMAC Telegenetics Landscape Survey was designed and approved by the IRB because we were motivated to be able to have the option to publish this information in the future. We sent out survey invitations to all those providers who had told us sort of in that first screening phase that they were doing telegenetics, and we also sent it out through the NSGC listserv, NIMAC News, and a paper mail invitation to all ACMG providers in the region. We also sent just a topic survey to all the providers who were not yet doing it but were interested to understand what their educational needs are. Between the initial inquiry and the survey, 63 telegenetics programs were identified that serve patients in our region. This number is still growing to date and includes national telegenetic services and laboratories and some telegenetic services outside our region that can reach our patients. Overall, 51 out of the 63 responded to the survey, and respondents were 88% genetic counselors, 8% geneticists, and 4% other doctors and providers. 77% of these services were actively providing services, 16% were in planning phases, and 6% were no longer active. And we had explicitly invited programs in all these phases of activity to respond. So when we looked at the preliminary findings, we see that many types of patients are being served, cancer and prenatal being the most common. 90% of programs have a genetic counselor, about 42% have a geneticist. Many patients are being served. Over 30% of programs serve more than 50 patients a month. When we asked what the programs are doing, we found that 81% of programs use some live video. 12% have instruments for physical exam. More than half of the services offer home-based services to patients, more than 75% of which can use live video. 74% of active programs have a wait time of less than a month, and right now, really little data is being gathered, and that which is mostly focused on patient satisfaction and experience, which has really been the case for most of previous telegenetics research. Many programs have significant experience. 69% have been around for more than a year, while just 16% were still planning. Programs really exist in various settings. 56% of respondents were in medical institutions, and they reach a long way. Over 40% reach over 200 miles, and most programs plan to expand in the future. Most of these programs responded that their motivation for their telegenetics program was to increase patient access and convenience. And with regard to how they work, there's a lot of variety in technology approaches. The program video was the most common video conferencing technology that was mentioned. Only 35% of these programs are billing insurance. 23% of them are completely free. Other funding included patient billing, contracts with other hospitals, grants, and also participants mentioned that licensure issues are a big challenge for many groups. So our original motivation in this whole exploration was to find the telegenetics providers and figure out how NIMAC could be supporting them. So the NIMAC Telegenetics Community of Practice aims to provide that support. The TCOP aims to be a group of providers who are practicing, have experience with, or are interested in telegenetics, who will meet periodically over webinar or conference calls to discuss their experience and strategies for successfully using telegenetics. The structure of the TCOP, as well as the topics and speakers, will be shaped by the survey information as well as the preferences of the members. And we had our first call about 2 weeks ago. So as we sort of reflected on the survey data, how does that help us with the TCOP? We feel that the data shows us that we really stand to learn a lot from each other. There's a lot of experience here. There was a lot of diversity in the way people were doing funding, logistics, and technology. We will also use the data for identification of topics and speakers based on trends. When we asked people about the topics they were interested in, those already doing telegenetics rated care coordination, reaching the underserved, and funding highest. And those interested rated funding, business planning, and technology highest. And we really felt like this represented the difference between extending versus launching a program. So our plan is for the TCOP to be a series of interactive webinars shaped by group feedback, as well as an interactive community in NIMAC's Basecamp system, where we can share the slides, the webinar summaries, we can post resources for telegenetics, and members have the ability to start discussions with other TCOP members on any topic. And you can hear more about the survey results and the TCOP tomorrow during the telegenetics session. So with that, I want to thank everyone at NIMAC again, as well as LUBA, and all the survey respondents and TCOP participants.